Hello everyone and welcome. For our 692 technology project, we will be presenting anxiety disorder in adolescents. Today's presentation is brought to you by Caleb Steen and Whitney Oliva. After this presentation, we would like our learners to take away at least 5 learning objectives. These learning objectives include being able to define what anxiety disorder is in adolescence and what it looks like. We would also like you to be able to describe and recognize the signs and symptoms of anxiety in adolescence. Thirdly, to discern risk factors that are frequently associated with anxiety in the adolescent population. Then to be able to identify screening tools and methods used for the diagnosis and treatment of anxiety disorders. And then finally to discover or innovate and to implement new treatment interventions for anxiety disorders in adolescents. Before we begin the presentation, we wanted to include a pre-examination to test the viewer's knowledge before the presentation begins and compare it to the knowledge gained at the end of the presentation. Please write down your answers and check for the answer key at the end of this presentation, which will be provided. Let's briefly discuss anxiety disorders according to the DSM-5. Later in the presentation, you will be shown the diagnostic criteria according to the DSM-5 for anxiety disorders. But I wanted to provide you with this video in lay terms to kind of help explain the topic at hand. Sometimes using different media helps the viewers if they are a visual learner. Let's begin with an introduction to anxiety disorders. Anxiety occurs in the daily life of almost every human being. It is normal to have a healthy level of anxiety, and this helps motivate individuals to get tasks completed throughout their daily activities. Anxiety may occur for adults during test examinations, if they're a college age, through strategic planning exercises or when implementing critical thinking skills at work, or even upon task completion at work. For adolescents specifically, their anxiety presents through imagery of their own self or through social interactions with peers and also in task completion. Excessive worry is not the only symptom you may see in anxiety disorders. Symptoms may exacerbate over time if they're not properly treated, and symptoms may, if left untreated, could result in personal or professional relationship issues. These issues could involve family members or friends or other peers, and then professional relationships. It could possibly impact their relationships with school teachers or college professors. There are different types of anxiety disorders. The 5 listed here are generalized anxiety disorder, obsessive compulsive disorder, social anxiety disorder, post-traumatic stress disorder, and panic disorder. Please take a minute to view the video. It's a great resource to help understand the specific types of anxiety disorders and how they impact the individual. Since our presentation is specifically referencing the adolescent population, I wanted to take a moment to detail about how anxiety disorder specifically impacts this population. Um, Anxiety disorders are the most prevalent diagnosed psychiatric condition in adolescence. Common signs and symptoms of anxiety disorders in this population include excessive worry, agitated demeanors and behaviors. It is also cited that depression and substance abuse with suicidality are common byproducts of anxiety disorders in adolescence. Due to these untreated symptoms, educational and social impairments may develop for the child, and children and adolescents who have GAD will frequently self-isolate and experience loneliness. As clinicians, we want to ensure that when diagnosing patients, we give them an appropriate diagnosis. To do so, we reference the DSM-5 and their diagnostic criteria. Per the DSM-5, the diagnostic criteria for anxiety disorders for adults and adolescents are as follows. For criteria A, the individual must experience anxiety and worry more days than not for no less than 6 months. Criteria B involves assessing whether the individual finds it difficult to control this excessive worry. For criteria C, the anxiety and worry are associated with 3 or more of the following symptoms. 1, restlessness. 2, fatigue. 3, difficulty concentrating. 4, irritability. 5, muscle tension. Or C, sleep disturbances such as insomnia. For criteria D, the anxiety and worry or physical symptoms must cause clinical significant distress or impairment in social situations, occupational situations, or professional situations. For criteria E, the disturbance is not attributable to the physiological effects of a substance, such as drugs or other medications. And for criteria F, the disturbance is not better explained by any other mental health disorder, including all other differential diagnoses. Let's discuss the pathophysiology of anxiety and also commonly occurring symptoms with this disorder. Anxiety disorders often express themselves through mood lability, decreased cognition, altered behaviors, self-isolation, and sometimes physical impairments. The etiology of anxiety is related to a psychosocial component, such as genetic components, environmental components, social interactions. They all play a significant role in the development of this disorder. Anxiety commonly occurs in adolescence and is most noted as the most commonly diagnosed condition in adolescence. Usually what occurs during this process is dysregulation in the central nervous system causes an excitatory response in the sympathetic nervous system. The neurotransmitters most commonly linked to anxiety are dopamine, serotonin, gamma aminobutyric acid, or GABA, and norepinephrine. Decreased activation in the serotonergic system causes a hyperactive response in norepinephrine, thereby causing anxiety in the adolescent. Commonly occurring symptoms of anxiety include chronic worry and fear. Let's talk about the neurobiology of worry and fear. Worry stems from the amygdala, the thalamus, the hypothalamus, and the hippocampus, which all are within the limbic system and regulate emotional processing. Anxiety occurs when dysregulation of glutamate and GABA overstimulates the limbic system. The neurobiology for fear is primarily due to the amygdala. The amygdala is the primary factor responsible for fear production. The hippocampus may assist in emotional regulation, but is impaired. This distressing stimuli activates a fear response often seen in anxiety. Multiple risk factors are noted for anxiety disorder. As you can see in the diagram, there are four main factors that can play a role in the development of anxiety. Certain risk factors include hereditary genetics, physiological triggers, learned behaviors and dispositions, or even certain environmental factors throughout the years. A thorough assessment of causative factors may aid in early detection and treatment of anxiety. Early symptom management may lower the risk for disease exacerbation and increase symptom control. Thorough assessment techniques and interview techniques are essential to making a proper diagnosis with all mental health conditions. For anxiety disorders in adolescents or in adults, these assessments and interviews can be performed by either physicians, mid-level providers such as physician's assistants or nurse practitioners, whether they're family nurse practitioners or psychiatric nurse practitioners. They can be provided by licensed clinical social workers, professional counselors, or even staff nurses. What you want to monitor for in these assessments is mood lability, nervousness, agitation, irritability, significant muscle tension, any sleep disturbances, any troubles falling asleep, and even concentration difficulties. Once the clinician conceptualizes a diagnosis for the patient, it is also wise to consider other differential diagnoses, which could be medical diagnoses or psychiatric diagnoses. Below you'll see how we've split the two types of differential diagnoses apart for better understanding. For medical diagnoses, a differential diagnosis could include asthma, hyperthyroidism, adrenal dysfunction, sleep apnea, epilepsy, COPD, or even cardiac disease, to list a few. For psychiatric diagnoses, the person could possibly be suffering from bipolar disorder, major depressive disorder, obsessive compulsive disorder, acute or post-traumatic stress disorder, panic disorder, anxiety disorders, ADHD, or even adjustment disorders. Please.
Hello. So for this side, we're going to be looking at some screening tools utilized for anxiety in adolescents. One of the first is going to be the multidimensional anxiety scale for children. It's a 39-item questionnaire that can be available for the youth to self-report or for the parents to self-report. There are versions for both, and it really assesses for any emotional, cognitive, physical, or behavioral symptoms of anxiety. One of Let's take a moment to expand a little bit on the SCARED screening tool, particularly the 71 item that is clinician administered. I'm going to break this down a little bit. The screening tool is utilized for a spectrum of anxiety disorders. It's utilized usually for children or adolescents ages 8 to 18 years old. Of the 71 items, 13 are on panic disorder, 9 are on generalized anxiety, 9 are on social phobias, 12 are on separation anxiety, 9 are on obsessive compulsive disorder, 4 on post-traumatic stress disorder, and 15 are on specific phobias. So if you're the clinician and your client is presenting, you can actually see here the breakdown for where this screening tool is more specific or sensitive on panic disorders, separation anxiety, or specific phobias, whereas it's sort of weak on your area for post-traumatic stress disorder. So if your client is presenting with a history of a traumatic event and you're trying to rule out that diagnosis, this may not be the screening tool to utilize for that client. This slide is really going to go into some clinical presentation of anxiety in adolescence. One of the more difficult things that parents, educators, and even clinicians may have to encounter is dealing with a younger population. They may display anxiety differently than adults or even older adults might display it. So some signs of anxiety in adolescents can be seen as difficulty breathing. That may be hyperventilation, complaints that they aren't able to catch their breath. Sometimes it can even look like intentional breath holding. Sleep disturbances. That covers a range of issues such as difficulties falling asleep, early waking. It can be nightmares. It may even be elimination issues at night, such as urination or defecation while sleeping, or the inability to sleep alone. Somatic complaints. That may be a very high amount of clinical presentation of anxiety in children. So you may notice that they complain of symptoms such as stomach or body aches that are not specific, headaches, weird sensations in their hands or their feet. Some may complain that they feel like their throat is squeezing or that their head is really tight. Separation anxiety or intolerance may be observed. There may be some fear of peer judgment or social judgment. Some patients do display physical symptoms such as elevated heart rate, sweaty hands, sweaty foreheads, excessive worry about school, assignments, the health or well-being of family or friends may be present. There may be some speech difficulties such as delayed development of speech, slowed or quiet speech, loud or yelling speech. There could be some rapid speech, voice tremors, stuttering, or even mutism. Fear that something bad is happening. That may be present. Displaying hostile behaviors towards family or friends, engaging in frequent fights with parents. It may not be uncommon for children to yell things like they don't love a family member or that they hate someone. Difficulty eating too little or too much. That may be a child that snacks very frequently. It may be a child who intentionally avoids eating. It is important to pay attention to that for development later on eating disorders. So as clinicians, after we make an official diagnosis, after screening our clients, the next step would be choosing a treatment option for our patients. Non-pharmacological interventions are going to be your first line of recommended treatment in children and adolescents. You're going to want to reserve those pharmacological solutions to if they don't respond to non-pharmacological, or if the display of behaviors is so significant to functioning that medications need to be trialed. Of the options available for non-pharmacological interventions, cognitive behavioral therapy is going to be one of the highest recommended and one of the most well-researched and evidence-based forms of therapy. The focus of CBT therapy is going to be addressing those cognitive distortions. Children and adolescents who present with anxiety often have a long list of situations, individuals that could potentially harm them. So it's going to be getting to that root thought process about what can potentially cause harm. Another focus is going to be on behaviors. An adolescent or a child may develop avoidance symptoms to where they just will not encounter what they fear will harm them. So CBT is really good at making some behavioral modification suggestions for that. Focusing on autonomic and somatic arousal symptoms. So a version of CBT called dialectical behavioral therapy, or DBT, is really good at looking into that parasympathetic activity during anxiety and addressing deep breathing, mindfulness, the presence of cold or hot sensations, and how that can stimulate a vagus nerves reaction to kind of calm down that anxiety response. CBT is largely assignment and homework based and can be tailored to the individual client. The recommendation is around 12 to 20 sessions. Another version of therapy for patients with anxiety would be exposure-based therapy, which involves taking the stimulus that causes anxiety and gradually and slowly exposing the client to that stimuli in the hopes of behavioral modification. The thoughts are that if they're experiencing it in a safe environment in slow, moderated doses, that will give the body time to respond differently to anxiety. Family-based therapy is also highly recommended. As clinicians, it's so important whenever you're dealing with adolescents to really look into their home environment, and family-based therapy can do that. It's working with the parent and the client to develop strategies and improve communication to improve home life. I can't stress enough as a clinician and as a family member of children with anxiety, how important involvement of school and community resources can be. So it is important to rope in that school counselor, get that 504 plan started at school so that these students may have a chance at minor adaptive strategies for school, or even an individualized education plan if the child does have a government covered disability. But these things are vital. They can provide the student and the child with additional test taking time, perhaps a different environment in which to take an exam, or a different educational plan pace that may be also necessary for the child to succeed in school. As clinicians, we're going to encounter clients and patients who don't respond or don't respond as well to non-pharmacological interventions alone. So we may need to look into pharmacological interventions. There is a lot of stigma surrounded behind prescribing medications to children. So I'm just going to go into a few of these that are for the treatment of anxiety. Serotonin is a neurotransmitter that is believed to play a role in the management of stress, anxiety, worry, and fear. One of our first line treatments for anxiety in adolescents from pharmacological interventions is going to be selective serotonin reuptake inhibitors, or SSRIs. And these are the only FDA approved medications that are in this group. That's going to be fluoxetine, fluvoxamine, paroxetine, and sertraline. They're also the most documented in this age demographic. So onset's typically going to be around 2 weeks. We may look at titration and continuing, of course, during follow-ups to see that we've made some positive improvement within a 12-week period. Studies are limited past that point in children. The clinician is going to have to follow up and determine how long the total length of treatment time will be for that patient. You're going to want to monitor for common side effects versus any of the severe or rare side effects. You're definitely going to want to educate and be mindful of black box warnings. SSRIs do have black box warnings for the treatment of child and adolescent conditions for suicidal ideations and behaviors of suicide. And it's all the way through age 24. So you're going to want to make sure that you're assessing your client at every visit for suicidal thoughts or suicidal behaviors. You're going to want to monitor for aggression, the development of mania, or some insomnia. You're definitely going to want to use these medications in caution with patients who have a history of seizure disorders. You definitely want to educate your patient and family members on serotonin syndrome and monitor it for yourself as a clinician as well. There is a lot of evidence to the efficacy of starting with subtherapeutic doses, especially since children go through developmental stages rapidly, their body and height distribution changes as they're growing. So it may be beneficial to prescribe that lower than therapeutic dose for a while with patients. You're going to want to monitor for abrupt discontinuation symptoms, and you're going to want to watch for drug-to-drug interactions. Now, support and education for treatment of anxiety disorder. I don't think that there's a slide that's probably large enough to cover all the areas that we would want to educate family members and patients for when it comes to anxiety. We'd want to provide them with documentation for how to take their prescription medications, side effects for those medications, disease process details, all of our psychoeducation, the role of genetics and anxiety, that would all come to play. But I would also probably go above and beyond and provide these additional support for that family and for that patient as well. I think that it's pretty rare to hear people discuss openly child suicide. It is a growing statistic, so I think it's probably vital to add the new updated suicide prevention hotline information. It's finally been taken down from a multi-digit number, which was very difficult for people to not only memorize, but to dial in times of intense stress and depression. So now it's been changed to 988, which is great. We can educate those patients that it's, 24 hours a day, 7 days a week. If you are not able to get your hands on an immediate resource, then this is here for those clients. I did attach some links for the Lifeline number and for the Anxiety and Depression Association of America for that psychoeducation. Um, just in case your patients really need a quick printout, that's a place that you can start as a clinician.
With all prescribed interventions, we want to set a specific goal or a specific set of goals for treatments. For anxiety disorders, we want to target the symptomology of anxiety and improve the patient's quality of life. Um, Providers aim to promote symptom remission and enable the patient with effective coping techniques to combat anxiety. Symptoms targeted are social phobias, isolative behaviors, physiological ailments, and also mood lability. And we also want to provide proper follow-up care for the patients. Usually if a patient is experiencing an acute crisis and they come up to the clinic for help, we want to normally set up a follow-up date for 2 to 4 weeks after the initial visit, just to evaluate any new treatment interventions that we have prescribed or recommended. Once the patient is stabilized on medications and with psychotherapy, we can see the patients every 2 to 3 months. And of course, for any increase in symptomology due to stressful events or emergent situations, sporadic appointments are available, and the clients are always encouraged to contact the clinic if they feel the need to come in for a visit before their next scheduled appointment.
So for this project, we were tasked with selecting which learning theory we thought applied most to our presentation. For our presentation, we selected the learning theory of connectivism, which is a newer learning theory that really looks into the way that electronic media is utilized to form a connection with individuals seeking knowledge. So the basis of this theory is that individuals learn best when new connections are made. And that's not just from a professor or a presenter's view to an audience or to students. That is one connection, but it's also looking at our new role as clinicians and providers and linking our personal goals to those roles as advanced practice RNs or as providers. So we really felt that connectivism was displayed throughout our presentation.
Now let's test our knowledge again on what we have learned through the presentation. Please take a moment to take the post-examination and compare your answers with the pre-examination provided at the beginning of the presentation. Now it's time to review the knowledge gained during the presentation. Please take a moment to review the post-examination answer key and see how well you did on each examination. If you wouldn't mind, we'd ask that you all take a moment out of your time just to evaluate this presentation to let us know how we did. Thank you in advance. For ease of access, we also wanted to include our YouTube links for this presentation for future reference. Thank you all very much for taking the time out of your day to view our presentation. We certainly hope you enjoyed it and were able to achieve the learning objectives set.